Let me begin by telling you a bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. CalMesa is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by CalMesa are funded by counties through voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides the funding and framework needed to expand mental health services to previously underserved populations and all of California's diverse communities. The Agency for Healthcare Research and Quality, Academy for Integrating Behavioral Health and Primary Care, functions as a coordinating center for national resources for people committed to delivering comprehensive integrated health care. The Academy focuses on integrating behavioral health care into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrating behavioral health and primary care. Key Academy tasks include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated healthcare, the Academy web portal and literature repository, where there are over 1,900 citations, and the recently developed lexicon for behavioral health and primary care integration, and much more. You can visit integrationacademy.ahrq.gov for additional information on the Academy. The Collaborative Family Healthcare Association is a nonprofit, member-driven, collaborative organization in existence since 1995. CFHA promotes a comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individuals and families, patients, providers, and communities. Advancing Care Together, a project at UC-Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to support cross-project learning. Before introducing Dr. Perry Dickinson, I would like to go over a few housekeeping items for GoToWebinar. So on the left-hand side of the screen is the GoToWebinar viewer where you are viewing the webinar. And on the right-hand side is your control panel where you can choose to listen to this through your telephone, which will display a call-in number, or also your microphone and speakers of your computer. At the end of the webinar, we'll have about 10 to 15 minutes for questions. So throughout the webinar, please enter your questions in the chat box at the bottom of the GoToWebinar control panel. And as a reminder, our webinar is being recorded, and we post all of our webinars on our YouTube channel, which is the CU DFM Policy Channel. Today, we are pleased to bring you Dr. Perry Dickinson. Dr. Dickinson is a professor in the Department of Family Medicine at the University of Colorado School of Medicine. He is past president of the Society of Teachers in Family Medicine, the North American Primary Care Research Group, the Board of Directors of the Annals of Family Medicine, and the Council of Academic Family Medicine. Dr. Dickinson has led multiple studies investigating the process of primary care practice redesign, focusing on practice facilitation, the implementation of the chronic care model and the patient-centered medical home model, and the integration of mental and behavioral health in primary care practices. He is leading the development of the Health Extension System of Colorado, a statewide collaborative effort of multiple organizations to provide coordinated assistance to primary care practices for practice transformation and to convene primary care practices, public health organizations, and community organizations for efforts to improve community health and to accomplish the triple aim. Today, Dr. Dickinson will present lessons learned from multiple integration projects and practice transformation. Thank you and welcome, Dr. Dickinson. I'm going to pass the screen control over to you.
All right. Thank you very much, Emma. Tell me when the screen comes over there. Okay, I see. All right. I think I'm there.
Yep.
All right. So it's a real pleasure to do this presentation. We've been doing work with a lot of both patient-centered medical home implementation projects that have included aspects of behavioral integration, and some other projects that have been particularly focused around integration of behavioral health into primary care practices, and also a couple of interesting projects where we've been doing so-called reverse integration, integrating primary care into mental health center settings. I think I don't want to go over a lot of the background for why this work is important, but I'm just going to give a little bit of background data and assumptions on one slide and then really dive in. First of all, I think those of us that have worked with PCMH implementation for a while clearly recognize that a patient-centered medical home or any other advanced model of primary care that is working without behavioral health integration really is likely to fail to fully accomplish the triple aim. Research has shown, first of all, that there's a very high prevalence of behavioral health problems in primary care. There's a lot of unmet behavioral needs in primary care populations, but also in the general population, and that these unmet behavioral health needs cost us a lot. And that integrating primary care and behavioral health improves access to health care on all levels, but particularly greatly improves access to behavioral health care. It improves outcomes, it reduces cost of care, and it improves both patient and clinician satisfaction. Oftentimes the clinician satisfaction and sometimes the patient satisfaction lags just a little bit because it requires some major changes to do this right. But long term, in the places that do this successfully, certainly clinician satisfaction pretty much across the board has been shown to improve. I think the baseline assumption that I'm operating from and a number of us operate with is that practice transformation to patient-centered medical home, to advanced models of primary care must occur to accomplish integration. And in order to be successful with behavioral integration is just a key part of that. So I'm not going to spend any more time on that, but just good to deal with basic assumptions. And so for some reason, there we go. The slide didn't want to go forward. So for truly integrated behavioral health and primary care services, the clinicians, the two sides need to be at very least co-located. I think it needs to go beyond that, but we'll talk about that more as we go along. This really diminishes the impact of stigma for patients. Patients can go to a single site to get the bulk of their care. It tends to be much easier for them to access that care, and it increases the likelihood that they will actually make use of behavioral health services. In particular, I think you could make the argument from the complex serious mental illness group that the presence of primary care and mental health centers greatly increases the likelihood that they'll access primary care services also. However, I'll have to say that I really don't think that co-location is enough. It's a great step, but the more behavioral and primary care services are tightly integrated, the better. So as a definition of integrated care, this is one from C.J. Peak that says primary care and behavioral health clinicians working together using a systematic approach to mental health and substance abuse conditions, health behavior change, life crises, and stress-related physical symptoms is kind of the core definition. I just want to point out that this does include, when I say behavioral health, I'm talking about both mental health, behavioral health, and substance abuse. And that's all included in that term, the use of that term. It's a good shorthand. This is a definition that's consistent with the lexicon for behavioral health and primary care integration, and is really kind of the basic framework that we're increasingly using as a model for the integration process. What we're looking for is integrated care that enables physical and behavioral health provisions, flexible, personalized, and seamless. So it's really providing care to patients when and where they need it. And it really, to do this fully, it's going to require a lot of integration efforts. Today, I'm going to focus particularly on the second box, the primary medical care box, where we're talking about mental health integrating into primary care. There are some key instances where integrating mental health and behavioral health into specialty medical care is also very, very important, and we don't want to lose sight of those. I think sometimes that is kind of on the back burner for a lot of places, but it's very important. And certainly looking at specialty mental health care settings like community mental health centers, integrating primary care there is also an important area of integration, as I alluded to earlier. Although we've had experience with that, I'm not going to talk about that today, in part because the experience has been that it's really a very different animal in a lot of ways, and it kind of requires its own presentation. So I'm going to focus predominantly on the primary, integrating behavioral health in the primary care setting. First, I'm going to just kind of touch on a few real basic best practices that we've identified for integration. First of all, physical space really matters. You know, behavioral health clinicians or primary care clinicians and mental health centers shouldn't just be in an office down the hall. They have to be integrated into the space, and sometimes it takes some redesigning of the basic clinical space to put everyone together into the same workspace at the same time. Part of why that's important, you know, looking at it in the primary care setting, is that the behavioral clinician really needs to be readily available for warm handoffs, brief interventions, you know, kind of with less time set aside for traditional psychotherapy. In situations where you're co-locating essentially a psychotherapist who's seeing a limited number of appointments for hour-long appointments and just kind of taking on some of the patients from the primary care setting, a co-located sort of situation where they're down the hall might work. But if we're really looking at integrating things, they need to really be readily available for the warm handoffs, as we'll talk about later. Just to say, you know, psychiatrists, clinical pharmacists, care managers, the staff in the primary care practice, as we'll discuss further, also have a very important role in tying things together in terms of this type of integration. You definitely need effective screening to identify patients for targeted intervention, and we'll talk a good bit about that later. But it's important to match the targeted patient population that you're screening to your capacity. Let's say you start having initially someone, a behavioral person in the practice for a couple of half days, or let's say it's a very large practice and you have someone there full time, but it's large enough to where as you start screening, you're identifying this huge backlog of patients with mental health conditions. You're not going to be able to serve them all and quickly outstrip your capacity. So it's really important to match those up. There are also, so basically there's an availability threshold for making this successful, and you really have to pay attention to that. And you also need a backup plan for emergencies, more complex situations, or patients who don't respond to primary care treatment. And that's a key piece of the system of treatment you want to implement. There are some key areas of patient-centered medical home or other advanced models, the comprehensive primary care initiative sort of framework also. Any of those models, there's some basic pieces of those models that are kind of foundational for behavioral health integration. And if those aren't present in the practice, it's going to make implementation of behavioral integration difficult. It's not impossible, but it is certainly difficult. I wanted to run through those fairly quickly. First of all, a very important part of the patient-centered medical home involves increasing the use of an advanced team approach to care, training and empowering members of the staff to work at the highest level of their knowledge, skills, ability, and licensure. A multidisciplinary team approach creatively uses the different skill sets within the practice to collectively share responsibility for meeting patient and family needs with clearly defined roles. And this really necessitates understanding the roles and abilities of each individual and the functions they provide, as well as providing training to reliably take on these new tasks. I really feel like the initial establishment of team structures, a team culture, and some team-based workflows is really necessary to enable the oftentimes much more complicated addition of behavioral health professionals in as part of the team. And it's just a basic piece of work that needs to be done early on. Second, data capacity, which actually is listed third on here, but that's okay. The successful implementation of comprehensive primary care and integrated behavioral health models is dependent on the availability of specific population and quality improvement data, including registry functionality. And practices need to determine how to maximize their current electronic or paper resources in order to obtain the basic data that's necessary for population management, quality improvement, point of care decision support, and other key functions. And then operationalize their workflow to maintain current accurate data and use it to inform quality improvement efforts. As you move into behavioral integration implementation, there's some special requirements that we'll talk about later. But this particular piece really is crucial in as a kind of a beginning stage development. Getting the data processes right really makes a difference. Third, the quality improvement and change management process is also crucial. Implementation of a team-based model for implementing major changes like patient-centered medical home or behavioral integration really is necessary to make that work, and particularly to make it work in a full team-based sort of model. And we'll talk a bit about that more toward the end of the presentation and what that should look like. Population management, the provision of services to the entire population of a practice's patients, and not just those presenting for care, is a central part of comprehensive primary care. You have to be, following up on the data piece. We need to be able to use information systems like registries to identify high-risk patients or subgrouping of patients with particular conditions that need follow-up or monitoring. And that's really vital in enabling management of these groups of patients. This capacity is particularly important with dealing with behavioral issues. For example, patients with depression, having a system for monitoring those patients, knowing where they are in their treatment, making sure they're coming in for care, etc., is crucial. And it is better if you're not developing that completely de novo just for behavioral integration. Again, you can, but it's nice having those, at least the beginning pieces of that in place beforehand, and especially data. Patient engagement is really, I think, an under-recognized piece of all this. True practice transformation really requires engaging patients as partners, both in the design of the transformed practice and in the patient's management of their health. Patients have often been kind of passive recipients of care rather than engaged as the active managers of their own care. And we know patient self-management support for depression or other mental health conditions is a crucial part of their care. It really requires a culture shift for clinicians, patients, and practices toward viewing the patient and family as experts in the day-to-day management of their health. And in this model, patient and family members fully participate through shared decision-making, the development of goals and priorities and action plans for care, with the resulting personalized care plans then used by everyone in the care team for coordinating and providing care. It's a common platform for really integrating the care. And that's a crucial piece that it's better if you have started before the behavioral integration, and then take it further as you do the integration piece. And finally, coordination of care is particularly crucial for patients with mental and behavioral health issues, making sure that the care is as seamless as possible, derived from a personal care plan, as we just talked about, and then with that personalized care plan used by everyone involved in the care of the patient to help guide that patient's care. That's a crucial piece. There are other aspects of PCMH that probably deserve attention, but I think those are some of the key ones. Here are some of the key areas that I think people need to be thinking about as behavioral integration competencies. And again, this is not all-inclusive. This is just identifying some that we think are especially important, and I'm going to kind of deal with each one of these individually. So partnership models. There are three main partnership models for behavioral health and primary care practices that we've been seeing so far in Colorado, at least with a lot of the efforts. First of all is primary care practices hiring their own behavioral health clinician. It can be an independent person that is hired in the patient, the person may be, the behavioral health clinician may be a salaried position, or they may be operating on a variety of different payment sort of arrangements. But the basic thing is that they're hired by the primary care practice or have a direct, relationship there. The second would be primary care practices contracting with a community mental health center, another FQH, or another sort of more mental health center sort of framework within the community for those services. And we're seeing that a lot in Colorado, as some of the mental health centers are looking at that as a service that they can provide and as a way of connecting into primary care. And a third that we're not seeing as much, but certainly is a possibility, and we may see more of that as things move forward, is primary care practices contracting with private behavioral entities. Now, each of these has its pros and cons. For a primary care practice, hiring your own person gives the practice more control in choosing the behavioral health clinician, making sure that someone whose skills are matched to what you want done in the practice, and it may simplify the business model oftentimes. However, the person doesn't necessarily come with connections to a referral system. And so, once the patients get out of the primary care sort of realm and need more specialized care, those connections may be problematic. Also, the training and support for the behavioral clinician can be an issue when it's just, the single person or one or two people in a large primary care setting. Contracting with another entity by the primary care practice provides those connections to the referral systems and other colleagues, but the mental health center or private company may not really quite understand the needs of the practice. And the identification, I just have to say that on the front end of doing behavioral integration, the identification of the appropriate and available resources for this partnership is just a critical first task. It may take some time to sort out. This is one of the things that we see that oftentimes delays things as the practice tries to roll this out and has difficulty finding the right relationship there. So that's something to start working on well and really look for a situation that is optimal for the community that the practice is in. Workforce training. Certainly behavioral professionals have to learn a primary care approach. This is a different model of care than the traditional model usually employed by most behavioral professionals, and I think everybody on the call probably knows that. This involves brief interventions, monitoring patients, but it's all in the midst of chaos and competing demands, doing consultation referral when necessary. It's a different pace and a different set of tasks. Primary care clinicians and staff members also have to learn how to effectively deal with a new set of communication and clinical issues as they focus more on the behavioral issues that are going to be arising, and that you'll be able to deal with more effectively with the behavioral professional there in the practice. So I think the key thing here that everybody needs to know is that it's not just the behavioralist who needs to learn and adapt to the primary care setting. Both sides have to learn, adapt, and change, and it's really a new model of care all the way around, and that's just critical in looking at the changes that need to occur, but also some of the training that you need. Team-based care. A good definition of team-based care is here: the provision of comprehensive health services to patients by multiple healthcare professionals with a collective identity and shared responsibility who work collaboratively to deliver patient-centered care. And I think you could add to that they use a common set of metrics for judging how care is being delivered. That's what we're trying to achieve. There are things that get in the way of that, and one of the key things that we've seen over and over again in our integrative efforts has been that the professional cultures for behavioral professionals and primary care professionals are just different. They often have basic differences in how they view healthcare. They may not understand each other very well. There's differences in the basic approach to health. There's certainly differences in the rhythm of practice, the time spent with practices traditionally, and perhaps in the training. There was a really nice quote in the early days of our Advancing Care Together project where one of the persons who was really working on this is a behavioral person looking in looking at the primary care setting and said, I need my behavioral health folks to speed up and my family medicine folks to slow down. And that's part of it, but it goes far beyond just the pace of care. I think a key piece of dealing with this is using team meetings to figure out everybody's roles, how people are working together, the workflow, of how this is going to be integrated. It doesn't. This requires a lot of work at the level of integrating this in practices, and we'll talk a little bit more later about how to use a team-based approach to accomplishing this. Data capacity, beyond some of the things we talked about earlier, we're getting data, getting processes for getting data out of the EHR. Certainly information sharing between behavioralists and primary care folks is a big issue, particularly the privacy concerns for behavioral folks, the sort of things that they're recording. Some of that is considered pretty private information and needs to be protected. Also, the documentation styles between primary care clinicians and behavioral clinicians is very different. Even if you use the, say, EMR system for both, the styles of documentation are so different that sometimes they just don't fit together very well. Behavioral EHRs, EMRs tend to be much more around, making room for narratives, whereas medical EHRs are set up around billing a lot and are these sort of kind of more specific sort of issues, et cetera. So the bottom line is our EMR systems are not very well set up to deal with this. This particularly becomes an issue where you have two different organizations that are, where you have a behavioral person from another organization who's in a primary care setting and trying to share information back and forth. But it's an issue no matter what. EMRs are really deficient in including important psychosocial information, including genograms, things like that, or spaces for the narrative information you need. You also need tools to assist practices in screening for psychosocial and health behavior issues, and those receptor sites for that in EHRs are really missing, for developing personal care plans and recording them, for prioritizing the goals, doing action planning, monitoring progress. So a lot of times practices that are doing integration really have to do some overlays with either separate systems that are closely tied or put a lot of money into revision of their existing EHR system to allow for some of these things to happen. We know that systematic screening and follow-up is critical. Without systematic screening, most behavioral issues go unidentified and unmanaged. But then screening has to be supplemented by staff and clinician training to identify issues. You can't just rely on screening questionnaires or whatever to flag issues. And one of the things you really don't want to do is have screening systems set up without a system to follow things up. I mean, that can be not only worthless, it's potentially harmful if you identify a lot of problems that the patients are struggling with and then you ignore them and don't follow up on them carefully and closely monitoring how the patient's doing in moving forward. So again, in looking at the workflow within the practice and what needs to be established, this is just a critical key piece. Then transitions and handoffs. This goes back to working on a team-based approach, but you definitely have to focus a lot of the attention on these transitions. What you want is hopefully ready availability of behavioral services during a patient visit. It doesn't have to be immediate, but it can't delay patients too long. You can't have the patients waiting in the room or in the waiting room for a long period of time for the behavioral person. That kind of destroys the whole flow of the practice and also is oftentimes harmful from a patient perspective and is not very patient-centered. So you really have to develop very careful workflow and language around these handoffs. This has to involve the staff. The staff members are key in it, along with the clinicians. And so everybody in the practice needs involvement in developing these workflows and in training on how to handle these well. Community partnerships. Now, this is important for, from a patient-centered medical home and patient self-management support perspective, certainly. But I think it particularly rises much higher in the level of importance for practices when they're doing behavioral integration, because practices really cannot have all the resources necessary for dealing with the behavioral issues of their patient population. We know that there are a lot of resources available through the community, through public health agencies, but that practices don't often know about these resources. They know about them in a sketchy manner, but they're not really connected with them. And from the resources perspective, they have a difficult time connecting in with the practices. They have all these resources available that sometimes go unused by the community because the practices aren't really making that bridging. So partnerships between practices and community agencies can really benefit both and can particularly help patients in dealing with these sorts of issues. And it's something you really do need to deal with as a part of the process of doing the practice transformation to implement integration. Without a business model, this isn't going to necessarily work, and we know that this is one of the biggest barriers that we have currently. Mental health carve-outs is a huge barrier. I'm not going to go into that in detail. I suspect everyone on the call knows about that. They've been successful in some ways in really providing a high level of care for some patients with serious mental illness, but it has really caused some huge issues in dealing with the sorts of things that need to be dealt with in primary care. Behavioral billing codes are oftentimes not turned on for reimbursement. Same-day billing restrictions where you have a primary care clinician seeing the patient and then a behavioral clinician seeing the patient in the same setting. They can't bill for both services. That's a huge problem for co-located services. There are workarounds that exist, and some practices have been very successful in doing those workarounds and making this cost effective. But I have to say that those aren't long-term solutions, and it's a struggle to make those successful. There's a lot of increased interest in this on the national policy level, I think is reflected by all the different groups that are involved in these calls and, as cited by Emma, and then also by a lot of the demonstration projects and others that are out there. And there's a growing number of programs to support this. It's moving toward pay-for-performance models that really do take into account behavioral issues, enhanced fee-for-service frameworks where you can bill for these services, per member per month payments to support this as a population-based sort of service that aren't tied to particular patients, but then with a move toward global payment that includes both medical and behavioral services within that global payment system. And we're seeing a lot of movement on this over the last couple of years that I think is creating some momentum, but this is something that clearly needs work and will need some support and work as you're implementing these systems. So after all this, that's a lot of work to do. I mean, you've got to become a patient-centered medical home or at least implement a whole bunch of the changes involved there. There's a lot of additional work that when you start doing behavioral integration on top of that, it just really looks daunting. And what we want to do, this is a lot to tackle and can be exhausting at the end of the day, kind of like this kid who's kind of I feel like this a lot of time it's at the end of the day. So how can you organize the change process for success and less burnout? A couple of things we know about this. One, the leadership of the practice, hopefully engaging everybody in the practice, and then also engaging any partners that you have in this process, have to create a shared vision for this change. It's better if you can build this off of shared values within the practice, and it's amazing as you start kind of trying to identify those shared values on the behavioral side and on the primary care side, across the whole primary care side. You can identify what the kind of key values are that lead you into needing to do this. But the leaders have to facilitate the creation of an initial shared vision to help everybody understand the destination, what they're trying to accomplish, and each of their roles in this process. to provide a context for the change so that you know kind of where this is coming from, and to engage everybody and move into action. I have to say that shared vision is oftentimes very, very important also as you kind of go along through the change process and get a few months into things and you start wandering off the task, and you can use the shared vision. You can look back at the shared vision and say, well, okay, what are we trying to do here, and get back on track. So this is a crucial first step that is required. Creating learning conversations within the practice. These are regular, reflective, whole practice meetings using data and using quality improvement tools. You know, usually these are quality improvement teams, but you also can do some aspects of this in huddles within the practice. You know, certainly huddles of staff and clinicians to talk about the needs of the patients and figure out the workflow for on a day-to-day basis can be real important for this. Another important piece of the learning conversation that I alluded to earlier is bringing patients, families, and communities into this change process. Also, we again, if you're going to be patient-centered in this, if you're going to truly tailor what you do to the needs of the patients need to be advising you on how to do this. There's a number of ways of engaging patients and families in this process. It can be done through patient advisory boards. It can be done. You can use patient surveys to get some of their opinions. The tighter you can pull in patients to the change process, engaging them in really advising what you're doing, even including them in the quality improvement teams that are kind of planning out the change, the better off you are, and the more likely you are to be really transformative and to design something that will really improve the care of your patients. And another of these is learning communities, where you have a number of practices that get together on a regular basis to discuss what they're doing. You know, each of them working on this, perhaps from slightly different perspectives, but each sharing their experiences, their lessons learned. You know, there's no substitute sometimes from learning from other people in the field who are doing this sort of work. And I would strongly suggest to anyone trying to help promote this, setting up some sort of learning community with regular meetings. That's a critical piece of this, but also for practices that are trying to do this on your own, look for other practices in the community that you can try to figure out a way to meet with and you know, or look around for collaboratives that you can take advantage of. I mentioned quality improvement teams, just a little bit more about that. Essentially, the quality improvement teams should consist of members that represent all areas of the office. In some smaller practices, that might be everyone. In larger practices, it may be key representatives. So you have someone from the front office, someone, one of the MAs, an RN, a care manager, the behavioral person, a clinician, you know. Usually groups of 6 to 8, maybe 10 people, sometimes smaller and very small practices. But again, a representative, diverse group that meets at least twice a month, preferably, oftentimes weekly, but you know, I think for most practices it works out about every other week for meetings to plan the implementation of these integration efforts. We use this extensively in implementation of patient-centered medical home. We've used it in implementation of integration. This works, and particularly if you're going to do this in a team-based model, and where this basically has to be a team-based model of care, you've got to do the change in a team-based model as well. So you use guidelines, some sort of model for integration. You decide on measures and data that you're going to use, and then use QI tools to move it forward. You know, plan, do, study, act sort of things, or whatever model for quality improvement or change that you want to use. And I'm not going to go into that in detail today, but you've got to use kind of a basic, good quality improvement change management sort of process, and then including process mapping, as I'll talk about in a moment. This really helps everybody as you're looking at the differences in the role identities and and kind of people coming from different places to try to accomplish this work, these sort of meetings really help you to develop an understanding of each person's roles, how they overlap, what the workflow needs to look like, and then plan training for everyone to get this into place. So this is a framework for doing the change management process that I think is critical. Workflow, it's really crucial to play, as I've kind of hinted at several times, to pay close attention to operationalizing the workflow for these new integration efforts. Part of that's understanding the roles, shifting expectations around crucial issues. You can use improvement teams to map out the implementation, obviously, as we just talked about, and then process mapping is a key tool. So process mapping is a way where you just walk through every aspect of a workflow. If you're looking at how are you going to do warm handoffs in the practice? How are you going to do the initial screening? And then if you identify a behavioral issue that the patient wants to work on, how you flag that for the clinicians, how you engage the behavioral specialists, how you do those warm handoffs, all those sorts of things are processes that you need to map out. And the process of mapping it out helps you to identify how you want to do it going forward and get it concrete in everyone's head and to have understanding so that this is not vague. The sorts of things you need to do is, first of all, decide on your target population. As we talked about earlier, you want to match up that target population to your capacity that you have for delivering care. Think and talk about the access and entry points to initiate integrated care. Who are the team members who are responsible for each one of the steps? Talk about how you're going to identify the problems through screening or through the staff. Then how you'll do the handoffs. So what are the treatment strategies? What are your protocols? What sort of decision support do you need for that? And laying all of that in. But then also making sure you deal with the systematic monitoring of patient progress and follow-up. So each of these pieces has to be mapped out very carefully, and process mapping is a great tool for that. I have to say, most practices out there don't have good practice level change management and QI processes. And I notice I underlined practice level. There's some practices that exist in large systems that have their own quality improvement processes that you oftentimes ignore kind of individual practice characteristics or staff engagement and kind of really deciding how to make it work on the practice level. And there's a place where you have to have good practice level team-based approaches to this to make these successful. And then if it's in a larger organization, figure out how this gels or kind of communicates with the larger system level QI processes. I'd say even when practices do have good QI processes in place, and certainly and especially when they don't have those in place, practice facilitation for major change efforts like integration can really help. The practice facilitators are people usually from outside organizations who can come in and assist the practices with implementation of the change management. They can connect people who are working on this with resources. They also can connect people with other practices that are doing this work so that you know that this practice down the road is working on this and has found a solution, and you can connect them up with each other so that they can learn from each other. The practice facilitators serve as a nudge to kind of keep the practice going, and over again as we do evaluation of these sorts of efforts and talk to practices that are working on these sorts of things, the practices say that the facilitators really kept them going, at times when they would have dropped off the work. So the practice facilitators also can help focus on practice culture, help deal with some of the issues around that, particularly the different cultures of the groups that are coming together, help in building those relationships, and then dealing with workflow through process mapping, et cetera. Most practices don't have some of these basic skills in place, and this is a way of bringing in someone to help them to do it, focus it around behavioral integration and connecting them up with a broad array of resources that can help. Now, not everyone has access to practice facilitation. There are states where this is being done very actively. There are places where this is being done for specific projects. I just encourage any practices out there that are listening in to look for opportunities to connect up and use practice facilitators to help them with this. And anyone who's planning these sorts of transformative efforts in your community or in your healthcare system, think about how practice facilitators can be deployed to do this well. I think I still have a few minutes. I think actually I'm going to skip over this slide and just move into questions so that we do have enough time for questions. So this isn't business as usual. This is really the development of a new model. It's not taking behavioral folks and kind of just cramming them into a primary care setting where it's business as usual in general, but you just got a behavioral person who's kind of doing their own thing there. It's really creation of a new model that's shared between the two. And it's important that you think about that and look at it that way. And at this point, I'm going to ask Emma to help me in identifying any questions, and I'll see if I can come up with some answers. My email address is at the bottom of the page here. I'd be glad to respond to any questions people have that they want to send me by email also. So thank you. Emma?
Great, thank you so much. So if you have any questions at this point, please just enter them into the little question chat area, or you can raise your hand and I will unmute you and you can ask your question verbally. And on your screen is the website for our YouTube channel if you'd like to view this presentation again or any of our other webinars. So the first question we have is, how do you suggest practices focus on mental and behavioral health when data points the need to address other chronic diseases such as diabetes, COPD, and asthma? How do you prioritize what conditions to focus on? Addressing mental health is clearly an extremely important issue as well.
Yeah. I think that's a tough issue in some respects because some of the meaningful use criteria, a lot of the quality improvement, pay for performance targets have tended to be set around other chronic issues and haven't included behavioral issues as you identify there. I think this is an area for people who are in systems, they really need to be planning out what are the key ways in which you can integrate in some of the mental and behavioral health measures and targets and as part of that process. I think we're seeing those increasingly crop up within plans for pay for performance and or other sorts of endeavors, but I think they're a bit lacking. The other piece of that is that some of what our behavioral folks do, some of what our practices do from a behavioral perspective is not easily measured through kind of traditional quality measures, and the sorts of things, and things like development of shared care plans, the development of action planning around patient goals. Our EHR systems are not well set up to capture that data. A lot of times we have to do our own work with that in terms of making sure we develop some type of registry functionality to supplement what's available in our EHRs. We definitely need to do advocacy around that to help make people understand the importance of this as part of what is truly necessary for enhanced primary care and enhanced healthcare services for our patients. So I think no matter what, we have to have data around the sort of services that we're providing here as a way of helping to guide us and to make sure we're doing what we need to be doing. And whether it's kind of included in some of the like meaningful use and other things like that or not, we have to develop those data streams, and that's a piece of work we have to do on the front end. But hopefully things are going to point more and more that direction.
Great, thank you. The next question is, how long does this type of practice integration development work last, and roughly what does it cost to do it? Can this type of integration be completed successfully in the absence of additional upfront financial resources from a payer, grant, or other resources?
Um, Total cost, I wish I had a better framework for that. There's some of the work that Ben Miller and others, including Emma, are doing here with a couple of projects trying to develop a better sense of the cost and the cost benefit, and et cetera. But I have to say our data on that, on the absolute cost to the practice, is somewhat lacking. And part of that is it requires costing out both the cost associated with hiring or contracting for the behavioral person in the practice, but also the time that it takes to actually do the change process, which is a cost in itself. So I wish I could give you a better answer on that. I can't tell you an exact cost. I think it also varies quite a bit about around where the practice is regarding other aspects of the PCMH model, how much support they might have from their healthcare system, and a lot of issues around just the practice, its context itself. It takes a little while. This is not something that is achievable overnight, and people who are thinking that this is going to be accomplished in a few months and then you're in smooth sailing are not thinking about this correctly. And looking at for a practice that has kind of worked on PCMH, has already done a lot of that basic work and has some of those processes that we talked about there in place, you could probably do an awful lot of this work in terms of the integration in 6 months to a year. But yeah, I think you're going to keep tweaking it for a while. I mean, it's not something that you're going to I wouldn't view this with a project mentality. I think patient-centered medical home and behavioral integration, you have to view both as a process that goes on over a period of time. So I just gave you a very, very vague answer. I wish I could be a little bit more specific. I do think it's, I think a year is kind of a good target to having some basic processes in place if you do this pretty aggressively. Maybe 2 years to really feel comfortable that you've got all the pieces of it down. I just think it takes a while to tweak it and make it fully functional. But, I think a 6 months, 9 months to a year process to you at least have a lot of the basic pieces of this in place to where you can feel like you're doing a pretty good job on it if you're laying that on top of PCMH. PCMH work from, if you're really looking at full integration, full implementation of practice transformation around PCMH, my experience and talking with a lot of other folks who've been working on that is that while you can get PCMH recognition a lot more quickly to really accomplish the full transformation that's needed, it's more like a 2-year process to do that. So this is, again, none of this can be accomplished overnight. You can do a lot of basic work to begin the process much more quickly, but you kind of have to stay with it.
And we have a participant who would like to share a resource with folks, and that is that the Massachusetts PCMH Initiative developed a behavioral health toolkit that is now available to the public, and you can access that by registering as a new user on their website, which is pcmhlearning.ehs.state.ma.us.
And that is a very nice resource. I've looked at it before. That one, also AHRQ has some very nice resources, obviously for mental and behavioral health integration, also including the lexicon for behavioral health and primary care integration that I mentioned earlier. There are a number of good resources that are popping up out there, and pay attention to those because a lot of those are based on experiences in states or programs that are a little bit ahead of the game in working on this.
So we could take another minute. If anyone else has any questions, please submit them to the chat area or raise your hand.
Just another mention about reverse integration or integration of primary care in mental health center settings. Again, I just want to emphasize that I think that's a very important topic as well. I like seeing partnerships where the integration is really bi-directional, that you're doing, people who are partnering to do uh, to, to really make this where there's no wrong door and that everyone can get the services that they need in the site where they're most comfortable getting care. And I didn't talk about that a lot today. It's just a whole other topic that really requires a bit of a different framework. A lot of what I talked about today in terms of the change process, in terms of aspects of what it takes to make some of it work, certainly applies. But again, a little bit of a topic for another conversation. So, Emma, we're coming up to the hour. Do you want to call it?
Yeah, so thank you so much for your presentation today, and thank you to all of our participants for joining us. If you want to take a minute after our webinar ends to complete a short evaluation, we would really appreciate that. And we look forward to everyone joining us next month for our webinar on reducing racial and ethnic disparities in primary care settings. Thanks so much.
Thanks, Emma.